Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attends every month and they suffer from otitis externa, as you can see here, and they also have a T-tube grommet, a ventilation tube. I did a video, I uploaded their last procedure, which is video number 1087. I will provide the link within the description. And on that occasion, the patient, the ear canal was infected, the dead skin was infected, so we referred them to their GP. Because they have an opening into their middle ear via the T-tube, the ventilation tube, they're not able to use your traditional antibiotic sprays for ear infections because they are what we call ototoxic. So these medications, if they enter the middle ear space via a perforated eardrum or a T-tube grommet in this instance, it can potentially cause permanent hearing loss. It can be in some way absorbed into the inner ear, the organ of hearing. And so therefore this patient was prescribed ciprofloxacin, which is a non-ototoxic medication for ear infections. Ciprofloxacin historically were solely for eye infections, but then over the years ENT and GPs would prescribe them what we call off-label for use in the ear because they're known not to be ototoxic. So in cases of perforated eardrums and grommets, and you've had an infection, they are suitable. And more recently, I would say in the last year or two, if I'm correct, the ciprofloxacin are now, they've also developed an eardrop version, so it's not off-label anymore. Now what can happen though, and if you refer back to the video from last month, and I said it's video number 1087, entitled Ear Tube Grommet Infected Dead Skin Peel. When you've got an infection like they did last time and they use some sort of antibiotic drops or sprays, the discharge in the ear becomes crystallized and the skin becomes very dry, this outer layer of skin. And you can see that although the infection's no longer active, you've got all the residual debris, dead skin that's crystallized. It's almost like a snake skin. And this is unbearably itchy for the patient. You can imagine, you can see how it's like. And so if this is on any other part of the body, you'd find it extremely irritable and itchy. And with it being in the ear, it's worse in some ways because although we advise not to scratch and itch because that can exacerbate it. The patient, even if they wanted to, are not able to get into their ear, not at least deep into the ear. So we're just slowly peeling this away. What makes, you may have seen at the beginning there was a bit of a puddle of fluid. Now that was just olive oil, so the patient used some olive oil as instructed by the ENT consultant as well who performed the grommet. And that's just, they just use it on the morning of the appointment just to soften that dead skin on the eardrum and inferiorly near at the base of the eardrum because that skin is extremely crusted and it's really, really difficult to remove. Now, remember, if you've been watching my videos, you're probably aware of the anatomy of the ear, but if anyone's new, I'll just explain the ear canal. So the average ear canal length is approximately, just to say, for argument's sake, 3 centimetres. It's around 2.6, but let's just round it off to 3 centimetres. You can subdivide the ear canal into two parts. Now, the outer third is made of cartilage and a thick layer of skin, which is about 1 millimetres in thickness. And then the inner 2/3 of the ear canal is made up of bone, and the skin that lines the bone is less than 0.1 millimetres in thickness, which means the inner 2/3 of the ear canal is very, very sensitive. Unlike the outer third, the cartilaginous portion, where you've got this thick layer of skin and it provides a bit of a buffer, and cartilage by nature is a bit flexible and malleable, whereas in the inner 2/3 you've got the thinnest layer of skin possible, really, directly on bone. So we're exclusively working at the moment on the bony part of the ear canal, and it's like that game of operation. We need to try and avoid touching the canal wall, because if we do, it's going to be really uncomfortable for the patient. They're going to jump, they can move, and potentially that can cause further trauma and injury to their ear. So it is a very delicate procedure, but I'm using a fine end suction probe here, and what a fine end does, it gives you more precision. So with a fine end, it's an attachment to the standard Zollner suction probe. it's almost like if anyone plays snooker or billiards, that's what it's called in America, I think. On a full-size table, you've got if the cue ball's away from you, and you can't reach with your normal cue, you have an extension almost. So it is an extension. You add it onto the tip of the suction probe just by friction, like a push fit. And the suction probe is a lot narrower, and it just gives you more precision. It also allows you to work more precisely, especially in narrow ear canals. And it's less noisy, so when we're approaching the eardrum, it's far less noisy. And it's less likely to cause trauma to the eardrum. Now, when we're suctioning, now the eardrum is quite resilient, more so than what even myself believed it to be. Because quite often I'm on the eardrum. You'll see it in a moment. I am on the eardrum peeling stuff away, as you can see at this moment. But nonetheless, if you've got a full-size suction probe, you're suctioning potentially your eardrum, so you've got to be careful. So with the fine end, it's less suction, so it's less traumatic if you do come in contact with the eardrum. So you can see here, just direct on the eardrum, we're going to need to avoid that grommet as well. You can see that grommet just to the bottom left. Just want to peel this away. No, it's really crusty. I'm going to come back for this, I think. I don't think I managed to remove it successfully on this occasion. But we've got to be so cautious. We don't want to, you can see that grommet so close. And so why has this patient got a grommet? So the patient has, whilst you're watching, obviously, it's more the same now. You're just going to be seeing me peel away the dead skin. You're going to see the suction, the fine end. I've curled it a little bit at the end. I've put a little kink in it. So it just creates an additional angle, which helps me to remove this dead skin safer. And so whilst you watch the rest of that, and I will obviously come back to any important bits, I'm just going to explain for any new viewers what a grommet or a T-tube, ventilation tube is. So behind the eardrum, we have what we call the middle ear. So it's a cavity behind the eardrum. The middle ear should be full of air, and the air pressure behind the eardrum should be the same as the air pressure in the atmosphere. So in the ear canal, for example. When the air pressure is equal either side to the eardrum, that's when our eardrum is most compliant and most mobile, and therefore that's when we hear the best. So the air pressure behind in the middle ear behind the eardrum is very crucial to our hearing. So what regulates the air pressure in the middle ear to ensure it's the same as the air pressure in the atmosphere is a tube called the eustachian tube. So this is a connecting tube which connects the middle ear, so the cavity behind the eardrum, to the back of the nose in the region called the nasopharynx. Now, the eustachian tube, under normal circumstances, is closed. But during the course of the day, without us even noticing or realising, when we chew, yawn or swallow, the muscles around the eustachian tube, where it connects with the back of the nose, they contract, and it causes the eustachian tube to momentarily open. And that opening of the eustachian tube, so it's an involuntary opening, although we can voluntarily do it ourselves by, for example, closing our mouth, pinching our nose and blowing into the nose, called the valsalva. It opens up the eustachian tube and the air pressure can equalise. So if there's not enough air in the middle ear, you've got air travels up the nose, up the eustachian tube, into the middle ear, and it pops the eardrum back out. And conversely, if there's too much air, air can escape. In addition, the eustachian tube, when it opens, any fluid that may have accumulated behind the eardrum, and that's because the middle ear, it's lined with a layer of skin that's secretory. So it's a bit like the skin in our nose. It's moist and it secretes mucus. So that can drain away as well. Now, if that eustachian tube, for whatever reason, doesn't open at the back of the nose, it could be the muscles are weakened, or just the eustachian tube is anatomically very narrow, so you're born with it, or there's congestion at the back of the nose, swelling, an infection, or large adenoids, or an obstruction at the back of the nose. For whatever reason, it creates a vacuum behind the eardrum because there's no more air. So any remaining air in the middle ear it's sucked in by the neighbouring cells, which means there's a void now, there's a vacuum effect. And when you've got the vacuum effect, the eardrum gets pulled inwards. And it's like when you're on a plane, when you descend on the aircraft, it's a similar sensation. And that can affect your hearing. It can cause otalgia, so earache. It can give you tinnitus, even vertigo. And it can also lead to a buildup of fluid. Because that eustachian tube is blocked, you can get fluid building up. So there's no more air. Instead, the middle ear is full of fluid. We call that glue ear. That can, if untreated, it can perforate the eardrum because it can burst. It's like a water balloon. The water balloon, you can only hold so much water. In the same way, the middle ear can only hold so much fluid, and eventually the eardrum can perforate. If that glue ear is infected, it can then infect the bone behind the ear called the mastoid bone, because that's porous, it's like a honeycomb structure. And if that gets infected, we call that mastoiditis. That could be very, very dangerous because that bone, it's just below the skull. So then that can infect the meninges, the dura layer of the meninges, which is the a kind of like a coating around the brain, full of, and it encloses the spinal fluid inside, encapsulates that inside the brain, that meninges, and if that gets infected, it can cause meningitis or a brain abscess. So that's the reason why the patient's got the grommet is because the eustachian tube is blocked. So we want air behind that eardrum to prevent fluid from building, but also to ensure that air pressure is equalised. So the ENT surgeon has put this grommet. Now this is a permanent grommet. In children, they normally have a temporary grommet around it lasts about 6 months. It eventually falls out. And that's because in children, they're quite often, their eustachian tube can get blocked because, in children, they're more prone to getting colds and sniffles, and the eustachian tube in children is all very narrow anyway, and as they age, it can widen, and the position of the eustachian tube, in children, it's a horizontal plane, but as they get older, it kind of aligns into a more vertical position, so gravity can help fluid drain. So the grommet, the T-tube, this is a permanent one, it's an adult, so because it's a chronic problem, they can't treat the eustachian tube, it's not going to, there is possible of the surgery, but they've been down that route and it's unsuccessful. So this grommet, it essentially puts a hole in the eardrum and it ensures the hole never heals again. So the grommet, in the middle of it, it's a hollow cavity, it goes through to the middle ear. Now, another short-term fix is like an ENT surgeon with a scalpel making an incision into the eardrum, so actually artificially perforating the eardrum. I'll come back to that in a moment. You can see I'm just back to that dead skin on the eardrum. I'm just going to see if I can peel as much away as I can, but we need to avoid that grommet. I don't want that grommet falling out. I don't want to push it any further into the ear, into the middle ear. So air can enter the middle ear through the grommet as opposed to the eustachian tube. So it's almost like a bypass. Because no air can travel behind the eardrum into the middle ear via the eustachian tube because it's blocked, it's not opening. Air can instead enter the middle ear via this tube. So the air pressure is constantly equal behind the eardrum and in the atmosphere. It can affect your hearing, but not as much as people think. It will affect the hearing slightly, but not dramatically. And also, any fluid behind the eardrum, it can possibly exit via this drainage tube, the eustachian tube. So just the last bit here, I've just re-angled the kink on the suction probe to get this last piece of skin. The patient was really relieved. The skin was like really shards of glass. So I'm really happy with that. You can see from the beginning of the video, the condition of the ear now. And again, the patient's going to have to come back in a month. It's just a regular thing. They're going to have to just have their ears cleaned. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.